Any suggestion about ablation after this presentation, but anyway, probably some space is still present for percutaneous ablation. It is a mini-invasive. What Guido showed us is a quite attempt to be radical also when most of us probably would think that there is no possibility of radicality in the operation, but sometimes ablation can have some space. The therapy, we have simple resection, but we have systemic chemotherapy, transarterial chemotherapy, ablation, intraarterial chemotherapy, and extracorporeal therapy. We should start also from this fact that 25% of patients present with liver metastasis when they have a first diagnosis of colorectal carcinoma, and after the operation, 50% will present new liver metastasis in 2 years. And this is an important point for whatever you do, being chemotherapy, mini-invasive, or even aggressive surgery. Untreated patients with unresectable liver metastasis have 5-year survival 0, with mean survival less than 12 months, and untreated patients with resectable metastasis have a mean survival less than 20 months, with 0 5-year survival. So any treatment that can assure a survival at 5 years can means that modify the course of the disease. For chemotherapy in patients with unresectable colorectal liver metastasis, and I don't know what unresectable is after the presentation with Lord Sirling, but we still must use this term. The response rate is 18-56%. There is a variability in the different series, probably due to the selection of patient, with a 1-year survival 68%, but still 5-year survival 0%. With any chemotherapy we can use nowadays, even biological chemotherapy. The mean survival is around 23-24 months, and there are EV adverse effects that affect the quality of life of the patient. In more than 35% of patients with colorectal metastasis, this is limited to the liver, and this is the reason for surgery and to afford this disease. In case of eligibility for resection and eligibility, now we know that is a very very opinable term. The median survival is 28-46%, and I would like to steal the first slide of Guido that is very, very interesting, very significant about the importance of the surgery in this setting. Resection is clearly less than 10% of cases. Also, this seems not true after what Guido says, but 5-year survival after resection in 58%, and 25% of patients after resection have very long disease-free survival up to more than 10 years. And this is the great result that should always force anyone that is diagnosing a patient with this problem to search all the possibility to remove the disease by radical surgery. However, there are exclusion criteria for extrahepatic metastasis, technical problem, comorbidities, and the high recurrence rate within 18 months after cortical resection. So repeated metastasectomy is not always possible, and we want just to see if percutaneous ablation, meaning invasive procedure, can have some space in this kind of patient. This is the possible indication for ablation: the age, comorbidities, refusal of surgery, previous metastasectomy, and new meds that can be resected because of technical or patient problems, are resected or potentially resectable, but they will require larger, difficult problem for the patient. Below and multiple metastases, I don't know what this means anymore after with the presentation, but extrahepatic metastasis could be a contraindication to surgery, but can probably for minimally invasive procedures when the prognosis is due to the liver metastasis, probably there is some space for ablation. Which are the problems of ablation with metastasis? The metastases are generally hypovascular, they have no capsule. You can have, like in hepatocellular carcinoma, an oven effect, and they have an infiltrative growth, like infiltrating hepatocellular carcinoma, and around we have normal liver. There is no cirrhosis. That could be, in a way, an advantage, but not always. So there is no indication for percutaneous implantation. Of course, we tried an experience in the 90, but we immediately know that even one shot with large amount of ethanol could be absolutely ineffective. If there is heat dispersion, there is an irregular and unpredictable size and shape of necrosis, and there is an high rate of local relapses. So this means that we need, in case of metastasis that are different from hepatocellular carcinoma, a more aggressive ablation, with more aggressive than in a hepatocellular carcinoma patient, with large necrosis area, with very thick safety halo, if we want to be effective and avoid the high rate of local recurrence rate. This is a single metastasis in a patient that has several problems for surgery, and the oncologist asked us, they had progression during therapy, and the oncologist asked us to perform an ablation, and the kind of ablation should obtain this patient should be at least like this, because we don't have the possibility to see the margin and to have the margin resected to be studied by histology. So if we want to perform this kind of therapy, we should always act like this. This is another experience with a single metastasis in the dome of the liver. This is the contrast enhanced ultrasound immediately after the ablation, and this is the result at the imaging. And this is the result at the PET-CT. You can see also PET show an empty space where there is an uptake before the treatment. Again, another PET-CT in the case of metastasis, colorectal metastasis, very useful, even if sensitivity is not very high, but is very useful because not always we can judge our result by the contrast enhanced imaging. Like in this case, it seems a very effective, very nice ablation on a nodule like this, but when we perform PET scan, we know that there is still the residual tissue, the neoplastic tissue in the side, so we reablate this patient. This is large tumor, large colorectal metastasis in hepatic dome, and to perform large ablation. This is the surgeons that try to stop me. And the limitation of the peritoneal ablation is the safety distance from mild bile ducts. We have seen that the surgeon can very nicely and finally refine his cutting with the device that device or no device, so just the finger that some surgeons use, but we have several approaches because we are the ablation is still and probably will be always a very grossly way to ablate metastasis. No? Sono i chirurghi.
When you said grossly, because
we have a problem with coagulation parameters, and but we must have a safe percutaneous approach. But we can ablate, in some cases, we can ablate this to have a better approach. In case like this, we have also used open ablation. Of course, Guido will not like this image, but in this case, we have a nice ablation of this metastasis and in acceptable times, and this is the result, and the patient had no local recurrence and no distant recurrence in 2 years. That means, and probably an important result in the liver. More negligible patient for surgery and intraoperative ultrasound can sometimes, at the same time of the resection of the colorectal carcinoma, through the ablation, even in not so skilled surgical equipe, when hepatic metastases are found in the liver, through the ablation, we can, in the same operation, try to get radicality. Of course, if we know that there are multiple metastases, we can schedule an hepatectomy, but an intraoperative ultrasound, when we resect a colorectal carcinoma, should always be performed in order to try, because if we found metastases, eventually they are very small metastases, and is very effective to perform, safe and effective to perform an ablation in that case. This is another example of a large colorectal metastasis treated with this PET-CT. We treat the patient by ablation, and this is the result. Again, another metastasis. These are just several aspects. The complications are not very frequent, but we can have hemoperitoneum, pleural fluid, subcapsular hematoma, abscess, portal thrombosis, and if we see at the more important series in the literature till now, we have an important 5-year survival that sometimes can compare with surgical series. And all these, most of these are very aggressive ablation performed. Just a slide for illustrating the test of time. That is an interesting suggestion that Tito Livraghi made several years ago, if we have a patient with a single metastasis in the liver from colorectal carcinoma, a metachronous metastasis, we can decide to operate on the patient, or we can decide to wait for the eventual the possible appearance of a new metastasis. In the meantime, in that 6 months, we could just wait and see, but it could be interesting to try to destroy metastasis by minimally invasive percutaneous procedure, and then to remove it surgically if no new metastasis appear in the liver. Then they start this experience, 88 patient with 134 metastasis with this diameter up to 4 centimeters. They performed percutaneous radiofrequency, and they showed complete necrosis at imaging in 53 out of 88 patients, 62%. And when they follow up the patient, they know that 6 patients had a long disease-free disease, so they could avoid resection and avoid any other therapy. And 37 patients had new intrahepatic metastasis, so this patient would have escaped the surgery, and 15 patients were retreated with radiofrequency, and 7 out of these 15 patients had a long disease-free survival. The incomplete necrosis was in 35 out of 88 patients, 37%, and 20 underwent resection. At follow-up, 1 perioperative death and 12 multiple recurrences were obtained from the surgery, not from the ablation. This means that 52 out of 88 patients escaped resection, and 23, 44%, had a long disease-free survival, and 29 early and an early post-treatment progression. Among resect patients, there was 1 death. So it's difficult to make a decision on all the thing that we are putting in our pot this morning. The RF ablation plus chemotherapy has also been tried in several experiences, and of course it seems that there is an advantage in when the two therapies are used together, and even with the more modern, the last release in the chemotherapy with biological agent, the mean survival in this patient does not exceed 25, 30 in the recently released experience. There is a substantial advantage, a substantial improvement of survival using both therapy together. And I want just remember that we can apply invasive procedure like radiofrequency or microwave even during the course of the chemotherapy. In case of this is an experience with solitary colorectal liver metastasis that compare resection and radiofrequency plus systemic chemotherapy, and the result seems to be very similar in survival. And with metastasis less than 3 centimeters, the radiofrequency efficacy seems actually similar to resection. I will at least confirm the impression, the test of time. In conclusion, it's difficult to actually make a conclusion, but we can try to say that radiofrequency is highly effective for liver metastasis less than 2 centimeters. There is a high rate of local tumor progression for metastasis larger than 3 centimeters at technical skill, aggressive ablation is required if we want to compare with resection. Thank you. I think that I was invited Guido come here and we can have some discussion about this and after we have the last presentation about this new ablation technique that is quite interesting and still strange in my I've seen some application but I will discuss this. But now I would like to try to have at least one or more take-home message from Guido. I don't have one. No. Any question? No question to the surgeon. It's not so easy to have a surgeon like this available. And this is the question, my question. How many surgeons? It's always the same question. I know you have to. No, I was using a bad word. You are already full of this question. But how many surgical team can perform what you showed us just a few minutes ago? How many in the world?
The world, in Japan, many. In Europe, a few. Because there is a disagreement, not only, I don't know if the disagreement is hiding a lack of capability. Probably, yes, to use ultrasound, not to do a surgeon. It's different. There are, and then the most utilized approach is the two-stage approach. We are just fighting this concept, but paradoxically, it's very hard to fight with this concept in a surgical community. And this is the same question that the surgeon raised to me. And then it's difficult. Of course, this technique showing such kind of results, it may provide two reactions. One is too much enthusiasm, believing that surgery can do whatever we don't, and it is frequent that we see patients with objectively also we cannot operate. We have 30% of unresectable patients, which is quite a few compared to the average, which is 70 to 80, but 30%
is 80%.
30% is high. And once you are focusing your attention on this patient, you have another possibility is that the number of patients which will be not resectable even by us will probably increase. Because when I show this patient in a meeting, the community, if the community is not surgical, will address to me also sometimes arrive patient that cannot stay standing. And then this is a patient addressing to the surgeon, believing that I'm a sort of, and then in rate, it is decreasing the rate of my resectability, because the complexity that is proposed to me, you know, the patient with 49 lesion was not the patient with 49 lesion at the first CT.
Yes.
If I see a patient with uncountable lesion or 49 lesion, it means that once I open the patient, there are 100 lesions. Then I do not consider surgery. But the message is another. Use ultrasound, but this is the message for the surgeon. And the other one is don't skip the qualified surgical consultation once you are deciding about the destiny of the patient. This is the message, only this. Technical skill is a question of ourselves and the possibility to, you know, we are, as a surgeon, I have to look to the generation below 40. So in 10 years we will have a surgeon that will do like this. Because nowadays, to a surgeon that has grown and is famous using right hepatectomy, left hepatectomy, right hepatectomy, left hepatectomy, removing the liver as they do, and it was claimed also on the TG1 on the right broadcast now recently, which is not a new technique, it's done in Germany, in UK, is the in situ ex vivo. It's well known, but it was claimed as a revolutionary. This is due to the fact that they have no skill in the use of the ultrasound. So there is a little bit mystification, but to this surgeon you cannot ask to become you know, as you know, to become a good ultrasonographer, it takes 5–10 years. At a person of 50, 60, he will not restart his career. And the community cannot say, okay, we will stop now, there is only something. Of course, it's impossible, it's not correct.
And this is about technique. I would have two provocative, very provocative question. I'm not a surgeon, I'm not an oncologist, so I'm outside, I can make this question. The question to the surgeon is, you showed all that, but which is the recurrence rate of that patient, and which is the survival of that patient? Yes, but is out of the course, I want to say, and the same. I want to make the question upside down to the oncologist. If you or a person near to you had, because this is the way we physicians should always think in our mind. If I had the problem, I think this is the better way to think of the patient if we want to take in charge the patient. If I had the problem, 20 metastases, would I try the surgical resection, or would I start a long but probably not very effective way through chemotherapy without considering surgery? We have one oncologist here. What do you think about this? We don't need the microphone, I think.
For me, chemotherapy.
Chemotherapy. So you wouldn't think of the possibility of radically remove the
20 metastases. I don't agree.
Even if the surgeon showed us that he can do that.
Professor possibly is very good surgeon, but chemotherapy, my opinion, is the only option in metastatic failure.
Opinion is opinion, must be respected. And the evidence is that no, I just answered this. The evidence is that of course when you are dealing with such a patient, you cannot say that this is not a marginal patient. There are two main problems. You could not come to the operating table during the restaging, and once you get the resection, you must accept a priori, and it is disclosed to the patient, that this will be probably not the only operation we receive, but you have also to specify that is the only way to hope the cure. just is decreasing the rate of probability, not below 0 or 0. If you do the other way, you can control. Nowadays, the highest rate of survival at 5 years with cetuximab is 9%.
No.
9% of
In
5 years.
resectable, in resectable patients, but in unresectable patients,
But
it's
we are talking about patients that commonly are considered unresectable. 20, as he said, 20 lesions, common believing is unresectable. So this is the population of patients. And there is a paper I show about them, MD Anderson, comparing those who underwent chemotherapy only and 2 stages, not the 1 stage. These are exactly the same population. There is a clear benefit. Also, in terms of the fact that surgery can provide the possibility to survive, it is undoubted. And it was shown in the 90s, before cetuximab, bevacizumab, FOLFOX, FOLFIRI, whatever you want. Then it's impressive that still nowadays there is reluctance. But you know, opinion is opinion. I don't. If I have 20 meds, I go to the airport, take the Japanese airline, go to my master, and please operate me. My only chance.
Yes.
20 colorectal cancer metastases exist. And in that case, I have not so many experience for metastatic cancer to treat. But in that case in Japan, many doctors performed chemotherapy first, and then downsizing, and some tumor effective. So 20 go to 50 or 10, and then go to some doctor perform surgery, some doctor perform ablation, and that's the way. And I know that one doctor. I think you don't know Dr. Sites in Kyushu Medical Center. He is very professional for microwave therapy, and he performed that in that case first chemotherapy. Then he is a surgeon, but he performed open, and then performed intraoperative microwave therapy, and sometimes reject, but mainly it's intraoperative microwave therapy. And his survival data is very good. That's my comment.
2 critics. One is nowadays you do like this, Kokudo, which is the chairman of the most important surgical department in your country, 1 month ago, and published last year their experience, and they did in their series up to a few years ago, chemotherapy was only 16% of patients and 5 FU, almost nothing. So nowadays, he said, we are obliged to use the chemo because the pressure of the pharmaceutical company is too strong. But I agree with you that it's not a good manner of, and I have confidence in the fact that the chemo has provided a good addition, but from this to substitute is totally without any evidence, And once you mention one case of one doctors and in Kyushu, I guess if this is ethical or not, because you apply something that is not clinically proven like surgery, 30 years of experience, tons of papers, on patients that can be operated. You should demonstrate. You should do that only in patients that cannot be operated. It's the usual way of doing something, no? Indeed, every paper writes unresectable patients were treated with. Otherwise, you know, on the unresectability, everyone is playing a lot because the concept is vaguely you know, standardized. To me, you know, is not proving anything to me. The experience of one center that probably, I agree that surgery probably will disappear in the future, but it is. The literature is the only way that we can discuss about, not the opinion. The literature is the literature.
I understand. Yeah.
For oncologists, one patient with 20 metastatic lesion of liver, no exit, only metastasis, liver metastasis, but lung metastasis, bone metastasis with only therapy for diffusion of disease.
I agree, but it's always a question of probability, not a certainty. I have no certainty, I have probability. If you have a high number of mets, the probability that you have other foresights elsewhere, it's high, but it is not 100%. This means, and you can remember that even the lung can be operated. And anyway, with probability, risk of the therapy, risk of the disease, we spend time with the patient and discuss with the patient and clearly show which is the benefit in one sense with the numbers, not opinion. And but we know that some of them is survival. Is more disappointing for us because the pressure of the patient become, you know, but and it provides a lot of discussion with the patient that want to be operated, and you know, it starts the concept of the miracle, which is not a miracle, it's just a question of number. You below the risk, the benefit of the treatment, but the benefit of the treatment must be clearly accepted. It's not my experience, it's the experience of, you know, in Japan, Makuchi did removal last year, after I reported 49, 98.
Yes, yes.
So,
too many.
So, Makuchi is not the first guy that you meet on the street, no? She is the father of the modern liver surgery. Then it means that 98 is probably too much. But in front of such kind of results, my first reaction is we have to investigate with caution because there could be a room. Not is a stupid. Makuchi is not a stupid. And then if he does like this, probably, maybe. I saw the first time I saw such kind of operation, it was in the 90, 22 resection, 22 lesion. The patient was operated 6 months later, there was no chemo. And then again, and then again. And there the survival of 30% for the more of 4 lesions, 10 years without chemo. Of course, if I propose the operation with 30% mortality, possibility to survive over 1 million, I agree with you. But these other results, it's difficult to say no.
I think zero mortality or 1%, 2% mortality is the first step for proposing, for suggesting the therapy to the patient. Because if you have 30% mortality or even 20%, I think it's not as acceptable.
In example, I receive, you know, you are, you know, a respectable opinion, but sometimes a lot of oncologists, I give say, no, you know, there is a lymph node in the intercava aortic space. We don't, there is a capitation at bed, so it's not resectable. Push, then you have to resect because it's technically 1 lesion. There is a lymph node. It's finished. And so we have to resist. There is this hysterical behavior among the 2 categories, you know. They are pushing and pushing. There was a discussion with one that persecuting me for months for a patient that I should operate with 3, 4 lymph nodes. It means that the disease has gone, no chance. No chance.
I think that because I could you just made a little reference to this issue. The fact that the patient is resectable, the time is wasted, and can become a resectable or still resectable for you anyway, but become a resectable for many other team. That I think that if there is a more large diffusion of this kind of surgery, legal problem of selection of patient could arise, because we that perform imaging, and if not just imaging like radiologists, but we are also taking charge patients, we face with this kind of problem of patient that is neglected, that is not correctly selected, that has the chance to have a radical therapy after 6, 8, 12, 18 months, there is no more this possibility. And you see the patient with 1, 2, 3, 4 CT, REM, and other and this is more and more frequently encountered. The problem is that at the moment there is not considered this problem for legal action from the patient. But if this start, your approach and the approach of the oncology, the approach of the, who perform ablation will become will take seriously will be taken seriously in consideration, and it will become everything very difficult.
No, working now is very difficult already. You know, the patient with 15 lesion that comes to my outpatient, I say, yes, technically it's resectable. The CT is 1 month later, and the 1 month after, pre-operatively, because we have a long waiting list, there is 13. I say, it's not anymore resectable. And the patient, why we waited? It means that there were already these nodules, no? So it's no need, but nowadays there is the claiming of the, you know, we are passing from you are died to you didn't do the miracle.
The problem
come with a lawyer.
The problem is
it's hysterical.
The problem is I'm not speaking on 15 metastases. I'm speaking on 1, 2 metastases that I as a pathologist I have experience with Ravello. Every week I see at least 1 patient or 2 patients coming to me that can be resected or can be ablated or can be anyway can have a local regional therapy sent for surgery because it's more than 3 centimeters or more than 4 centimeters because there are one is below by 1 year, another year, and they are considered not curable and they are sent for surgery. Is because of the industry because of the manufacturer of chemotherapeutic agent? Probably. I don't know. But this should be a debate of legal action. Now, any other question?
Just one question. In the case of severe stage hepatitis, will you perform with surgery or not? Do you look for stage hepatitis before?
We have the data of the steatotic patients, but we do it. The main advantage is that this kind of approach is coming from the experience in the ACC. Then the fear of facing with the steatopapitic liver is lower than the other team because the cultural background of the North American surgeon is not has not the habit to face with the cirrhotics, quite recently due to the immigration and so on, but and most of them go to the transplant. But the other way is facing with the compromised background liver, and then steatohepatitis, it's a source of probably some more morbidity, but not mortality. We have no mortality. So difficult to compare if you don't have such kind of event. Indeed, the good paper about mortality and morbidity is done by Switzerland. They have a very high rate, and then they could produce classification. For us, it's difficult to produce a classification of mortality result, luckily.
Another question? So, we have sfogliatelle, caffè, why now? Then we decide